Alec, I'm going to pose a sort of a question. So assuming that probably both of these agents will get a indication approval for use in the M0 CRPC patient, what do you think the likelihood of urologists, they see this meets the definition, they've got the PSA going up, and they're asymptomatic, you now have potentially a couple agents that are approved. What do you think the likelihood of community urologists or medical oncologists say, I'm not going to scan, I'm just going to give them one of these oral agents?
I think that the temptation is great. Urologists traditionally have been very comfortable with giving bicalutamide, and I still see patients from some of my partners or some of my retired partners who have passed on to me who in a similar setting have been on bicalutamide for a long time. So a lot of urologists are just comfortable with the concept of giving an oral anti-androgen in various settings. So this completely segs in that mindset. That being said, our approach really should continue to be a systemized fashion. I assume that PSA doubling time is going to be an essential factor in determining eligibility for treatment. And most urologists aren't calculating PSA doubling time. But in a systemized navigator program, then the routine checking of PSA level and calculation of PSA doubling time should be incorporated, based on whatever the criteria is that may accompany these medications.
But what about the imaging? What about the baseline scan? Because I can see this. I can see a busy urologist, his PSA is going up, that, he doesn't want to spend the time to have this lengthy discussion that we have, and he'll just say,
well, that's how you use bicalutamide, right? In this setting, right? These guys wouldn't necessarily go and restage them all. They'd just say, PSA's up, I'll add bicalutamide. Right? So it's analogous.
And so what is wrong with that approach then? If even in a systemized fashion, you're tracking all your patients, you're calculating doubling time, these are CRPC patients, now have this PSA doubling time, and just start them on medication.
To me, it's a problem of, again, not knowing where they truly stand from a metastatic standpoint at baseline, and so therefore you can't really know when they've actually progressed if you don't have a baseline scan.
Well, no, I think the reality is that a lot of these patients, right, we've been obtaining bone scan, CT scan. Obviously, they've been negative, so they're still in this M0 space. You hit the doubling time threshold, you start treating them. And so the question is, do we use more advanced imaging to try to document metastases, or do you just continue to do the bone scan, CT scan, and knowing that now in this world is not sensitive, is not going to detect the metastases, but you have the new medication now that you in fact can use.
So I would hope that doesn't happen, that people just reflexively puts folks on drug. It's because, the criteria that we typically talk about looking at is to make a change to the next line of therapy would be the patient is either no longer clinically benefiting, which has a sort of vagueness to it, but is symptomatic exacerbation, number one. Number two is new lesions. And how do you know if there are new lesions if you didn't get baseline scans to know where your existing lesions were? As a sort of a subset to that argument is, I like to know if somebody has got their spine riddled with disease versus their liver versus just soft tissue adenopathy based upon correlating with their symptomatology and other adjuvant treatments that I might be thinking about later on. And of course, if you're a trialist, you'd want to know where their disease is too. So, and then the third part is, where your laboratory values are, if they're outward, if they're outside normal range, where your scans showed where the disease was. So I hope that our colleagues don't just reflexively, because of, too busy in their schedule. I'm still thinking back to your comment that you made about, I got 30 minutes to go and I have 10 patients to see. That would be 3 minutes per patient. That's a tough day in the clinic.
That's exactly right.
That's if you run on time.
That's right. That's right.
Can I ask one other question related to this? I think what Neal brings up is really important. And if for nothing else, just prognosis, it's helpful. But I think it is helpful for future comparisons as well. But the other aspect of this was the safety. And the concern I have, and I'll be interested as urologist how you all feel about this, because it's not what you think. It's not necessarily safety totally directed to the therapy. I mean, yes, there were slight higher increases of fracture or dizziness or falls or fatigue. But to me, the concerning things was the deaths. There were deaths on study, in both studies. You see about 3 to 5% of deaths in both arms, the placebo and the treated arm. And if you look at the treated arm, these patients are on treatment for 2 years longer. So naturally, they're going to have some deaths on treatment that are unrelated to the drug. These are kind of natural history deaths. I mean, they can be things from pneumonia to infections, other infections to cardiovascular or stroke, other cancers or other complications. When we look at patients who aren't part of clinical trials, they tend to have more issues that would have excluded them. So my question is, this is a population that if you know that 1 in 20 are going to die from other causes during the time that you're following them, is that a population of patients that you want to involve, again, that sort of multidisciplinary care that sort of brings in palliative care and some of the other kind of hospice and other services that can kind of go along? Or is that a population you're comfortable sort of saying, you know what, I'll just manage them and I'll leave it to the internist to deal with these other issues? Because it seems like whoever is sort of actively managing this is going to see the patient probably more than almost any other doctor is during that time frame. It kind of carries that responsibility.
So Alec, you're in a great position to actually address this because your practice is one of the only 2 community practices that are actually enrolled in the oncology care model in the OCM. So again, your kind of response to Dan's question or comment.
So I really have to think about this one because, so first of all, from the study, like you said, the incidence of grade 3, 4 toxicities are low. They're in the order like 2 to 3% over the
each one, yeah.
Right. So the drugs themselves by that are fairly safe, and so and death, there's certain type of death that is unpredictable, right? So, but if you have a patient who in fact has poor performance status, who looks sick, and I think that does come to the judgment of the physician of whether or not to start this medication. And it's an incredibly complex question. Right. Patient could be there with families or PSAs rising, and they want dad or grandfather treated, and they're focusing on that. I mean, all these factors come into play. And at the end of the day, it probably really only affects a small percentage of all the patients.
Yeah. It's hard to do it in 3 minutes.
Right. But I think you're right. Great points. I think as Phil said in his talk, that we really do have to be paying more attention to the benefits, the risk benefits, and the quality of life issues that come along as we manage these patients. Great discussion.